Our next speaker is none other than Dr. Guillermo Umpiras. He's the president-elect of ADA and a good friend of mine. It's a pleasure and honor to introduce him. He's, of course, the professor of medicine, the Division of Endocrinology, and clinical director of Diabetes and Metabolism Center at the Emory University School of Medicine in Atlanta. He also serves as the director of Diabetes and Endocrinology Section and Clinical Research Unit at the Grady Memorial Hospital in Atlanta. He's a recipient of numerous teaching awards for Best Clinical Teacher and Best Mentor for Endocrine Fellows and Junior Faculty at the Emory University, and has received several national awards from the ACE, American Association of Clinical Endocrinologists, American Diabetes Association, and as I said, that he's just the president-elect, and hopefully we'll be able to see him in a physical meeting next year at the ADA. He's also the member of the Diabetes Scientific Council and Board of Directors of ACE and the ADA Professional Practice Committee. And he's the editor of ADA's Therapy for Diabetes mellitus and related disorders. Today, he's going to talk to us on GLP1 RA and cardiovascular outcome trials. So over to you. The stage is yours, Guillermo.
Well, thank you. What a great lecture from Dr. Kosipor. And it's so hard to follow this type of lecture. Nevertheless, I'll try my best, Sanjay. So we're going to talk about GLP1 and how this type of medicine has really changed our position from the ADA and clinical guidelines. Before I start, I would like to just mention that I don't receive direct compensation from industry. However, I'm involved in multiple clinical trials. The money goes to Emory University. And I will try to do is to review the metabolic effects of incretin-based therapy or GLP-1 in type 2, outline the effects of GLP-1 on cardiovascular and renal outcome in patients with diabetes and in patients at high risk of having diabetes, and review the 2021 ADA guidelines and how these guidelines likely to be changed in 2022. So I'm just going to start as a very basic point that all of you know. Chronic kidney disease and cardiovascular disease, as mentioned by the previous speakers, are two most common comorbidities in patients with diabetes. Up to 40% of patients with type 2 will develop chronic kidney disease. The risk of cardiovascular disease and mortality increased by 2 to 4-fold in patients with diabetes. And heart failure, as I mentioned by Mikhail, increased by 2 to 5 points. So during the past 20 years, there have been multiple studies trying to understand, can we change the natural history of these complications? So of course, as a diabetologist, we say, well, if we treat diabetes, if we treat hyperglycemia, can we reduce cardiovascular events? And there had been multiple trials with every drug for type 2 diabetes up to a few years ago, and they're all negative. For example, the ADVANCE trial, conducted mostly in New Zealand, Australia, and Canada, and other countries. And it shows that using sulfonylureas or insulin secretagogue based therapy, there was no difference in mortality. The ACCORD trial, 10,000 patients, similar numbers at the ADVANCE, with multiple agents trying to bring a hemoglobin A1c very, very low, less than 6.5%, so normal, compares to 7.5, and no difference except that increased mortality. So if you try to push too hard, bringing the blood glucose down, you increase mortality. The study was stopped because there was a 22% increase in mortality. And here to the lower left, you had the VADT, the Veteran Administration Diabetes Trial, a much smaller trial of just 3,000 patients. Again, trying to improve as much possible glycemic control less than 7 did not change on cardiovascular events. And all of these trials have shown an increase in hypoglycemia. And hypoglycemia was a predictor of all-cause mortality. So frustrating for diabetes. What about treatment of hypertension? Well, maybe if we correct hypertension, can we really prevent kidney disease? And the trial for this come from maybe 20 years ago or more. And here I have using losartan and ACE inhibitors, and to the right, irbesartan, an angiotensin receptor blocker. And these trials were very positive, and this is why we recommend to use ACE inhibitors and ARBs in everybody who has diabetes and proteinuria or kidney disease, because they were shown to protect the kidneys. However, when you look at this trial, they reduced by 20%, but there is a significant residual risk. So how many patients you have in your clinic that you start ACE inhibitors or ARBs because they have proteinuria, and unfortunately they progress? So what we have right now is that we have two types of agents. One is the SGLT2s, and you already listened to Dr. Cozy Boro on all the benefits of SGLT2 and how they have impacted on clinical guidelines. My job in the next 20-25 minutes is to discuss the GLP1 receptor agonists, the impact that they have both in cardiovascular and renal protection. So what are the GLP1 receptor agonists? Of course, for many, many years, we know that GLP1 and GIP is secreted in the gastrointestinal cells. And the GLP1 was increase insulin secretion and suppress glucagon, and because of that, improve glycemic control. And we know that GLP1 stimulate insulin secretion in what we call glucose-dependent manner. So the risk of hypoglycemia, if they use by itself, is very little. They also inhibit gastric emptying. So by increasing and we will see some slides about that, of course, that reduce postprandial hyperglycemia. Perhaps one of the effects that my patients like a lot is that they increase satiety, and because of that and others effects may be associated with some weight loss. And finally, inhibit glucagon. And as you know, glucagon is the most important glycogenolytic hormone. So it breaks down glucose stores in the liver, therefore it decreases glucose in the circulation. So multiple effects. We have now several of them, and I like to divide them when I talk to my patients in those who are using daily or weekly. And here you have daily, and the only one in the United States that is now available is the liraglutide. And we have the weekly that is exenatide, albiglutide, dulaglutide, and semaglutide. They work in a different ways. That's right. If you look at the short-acting, half-life is very short. Liraglutide has a long half-life of 13 hours and is used daily. And then you have semaglutide, dulaglutide, where the duration is up to several days. That's the half-life. So because of that, they're given on a weekly basis. And all of them are associated, and we'll talk about side effects. You start in the very low dose and you build up your dose. So if you look at studies on glucose, and here you have compared to different agents, liraglutide in blue, albiglutide, dulaglutide in orange, is commonly used now in the United States. And you see that they are associated with the reduction of hemoglobin A1C somewhere between 0.8 to 2%. So it's as effective or more effective than any other agents, and equally effective to insulin therapy. But there is more than just glucose. That's right. We mentioned the gastric emptying, regulation of appetite. Let's review them, and then we go to the cardiorenal team. So this slide shows the effects on gastric emptying. And here you have that given a GLP-1 infusion, you significantly slow down gastric emptying. Just for your information, You may be asking yourself, well, how long did it take my stomach to empty after I eat a meal? About 75 to 90% of the meal that you eat or you consume is past the stomach in 2 hours. And what you have in here is that with these 2 hours, look at the placebo versus GLP-1 effects, the percentage that is emptied. And of course, if you don't empty your stomach, you're going to have a decreased postprandial effect. The other effect is the change in appetite because it increased satiety. So you remember when we went to medical school, patients with diabetes are polyuria, polydipsia, and polyphagia. Because this sense that the signal from the stomach to the brain and the brain saying, yeah, you ate enough, is lost in many of our patients, and with or without diabetes. And what you have in here, if you use the GLP-1 here in orange, compares to placebo, you change the hunger and you improve satiety. And this has been replicated for multiple of these GLP-1 agents. So if you increase satiety, you eat less, you are going to be associated with improvement in body weight. And what you have in here that you're going to lose somewhere around 1 to 3 kilos at the dose that is used in patients with diabetes. In addition to the weight loss effect, you're going to have, multiple studies have shown that GLP-1 is associated with minor but significant decrease in blood pressure medicine. And this has been shown, in this case with liraglutide, has been shown with other GLP-1s, and compares to placebo in yellow, the low dose and high dose 1.2 and 1.8 milligrams of liraglutide, improvement even before you see changes in body weight, you have a 4 to 6 millimeters of mercury reduction in blood pressure. And more importantly, same as the SGLT2s, now we have several studies that have shown cardiovascular benefit. And this has been shown with liraglutide, with semaglutide, with albiglutide, and dulaglutide. And I'll show you a paper that was published yesterday with other GLP-1 receptor agonists. So, LEADER, a transformational study on 9,340 patients, most of them with cardiovascular disease, 80%, or a high risk of cardiovascular due to multiple hypertension or other cardiovascular risk factor, who had a hemoglobin A1C greater than 7 in a short study for 3.5 years, where patients on top of their diabetes medicine were added liraglutide or placebo. And this study was the first one to show a reduction in what we call MACE, major cardiovascular outcome, that defined in most of these trials that I'll present to you in non-fatal myocardial infarction, non-fatal strokes, and death from cardiovascular causes. And a reduction of about 20%, 13%. And here you have death for cardiovascular causes decreased by 22%. And this was seen within the first 3 years of trial. That was liraglutide. A similar study was done with SUSTAIN 6 with the use of semaglutide. I'm sure you are using semaglutide. It's once a week, have the same side effects, the same efficacy in reduction of hemoglobin A1C and blood pressure. And they took patients, 80% of them already with cardiovascular disease, and they were treated with oral agents with or without insulin. And similar to the LEADER trial, they were followed up for 3.5 years. And amazingly, the results on MACE, cardiovascular death, non-fatal MI, and non-fatal stroke was reduced by 25%. So a very impactful clinical trial. Here you have non-fatal myocardial infarction decreased by 25%. Non-fatal stroke decreased by 40%. So 2 trials so far showing that they have a significant impact on MACE. Similar trial has been conducted with other GLP-1. This one with dulaglutide, close to 10,000 patients with the previous cardiovascular events or with multiple risk factors, again, with type 2 diabetes, oral agents with or without insulin, and you have a reduction of cardiovascular outcome of 22%. It's clearly significant. However, in this case, the mortality was not changed. IDEC2021, it was taken off. It's not in the market in the United States. But this study shows that MACE significant reduction, 22%, and you're going to see that the reduction of myocardial infarction of 25%. Although in this trial you didn't see much effects on stroke or cardiovascular death, but with respect to MACE, they show a 22% reduction. And in a paper that I don't know how many of you have seen it was published yesterday in the New England Journal of Medicine with this new GLP1 epegletnatide. It's not today approved by the FDA, but took about 6,000 patients that were randomized to a GLP-1 receptor agonist, 406 milligrams versus placebo. And this is on top of all of the other diabetes medicines. And what I'm showing you here is MACE, and it saw a reduction of 27%. So similar what you saw in the semaglutide and the liraglutide trial. And here to the right is the renal composite outcome that consisted on a reduction of urinary albumin creatinine ratio of 30% or more, a decrease in glomerular filtration rate more than 40%, of renal replacement therapy, or sustained eGFR less than 15. So incredible results published yesterday in the New England Journal of Medicine. So when you look on the cardiovascular protection of these agents, you're going to see that the leader, sustain, excels, and harmony, very short, very, very potent, and although not the elixir that is a very short-acting, that is not even available in the United States, the lixisenatide was not significant. But it's amazing. If you get a composite of this thing, you get about a 15 to 25% reduction in major cardiovascular events. So why is this important? Because all of the guidelines, especially the American College of Endocrinology and the American Diabetes Association, this is in Spanish, have recommended that if you are going to use an injectable, you should choose a GLP-1 much better, much faster than the use of insulin. So if I'm in clinic and I have a patient already in 2 oral agents, and I'm going to think about using insulin, I may think first to use a GLP-1 because it's not associated with hypoglycemia, has similar reduction of hemoglobin A1C, and have cardiovascular protection. All of them has been so far injectable, that's right, but now we have the oral semaglutide, and the pioneer, there are several studies show that the oral semaglutide is associated with similar reduction in body weight and hemoglobin A1C compared to the injectables. And in several trials compared, for example, with EMPA, it has a better reduction of hemoglobin A1C, similar weight. Sitagliptin, significant improvement in hemoglobin A1C and weight loss, and sitagliptin has very little effect, that's right. So now we have an oral GLP-1 that may be increasing utilization all over the world because it's shown to have a better improvement in hemoglobin A1C, a better improvement in weight gain, and also on renal protection. And just to complete, you have to keep in mind that about 30 to 40% have gastrointestinal adverse events. And that is the reason why you start at a low dose and you increase the dose as tolerated by the patient. So you start in a very little dose. This should not be used in patients with pancreatitis, same as DPP-4, or in patients who has history of medullary thyroid cancer. And of course, the main problem that I see around the world is the high cost of this medicine, which of course is significantly higher than the others. So, no questions about GLP-1. With respect to cardiovascular outcome, what about renal effects? Well, the story here is very similar to the SGLT2s. all of these trials have shown an improvement in renal protection. So here you have in the liraglutide, the LEADER trial, and this shows the composite renal outcome that was new-onset persistent macroalbuminuria, doubling of serum creatinine, or a GFR less than 45, or the use of dialysis. And looking at these composite effects, you see that the use of liraglutide was reduced by 22%. And persistent macroalbuminuria, one of the most important cardiovascular risk factors, because it's associated with increased risk of acute myocardial infarction and cardiovascular death, was reduced by 25%. In a different trial, this was done by Catherine Tuttle, that she will be presented tomorrow in this Congress. She conducted a dulaglutide in a trial that is called AWARD-7 and compared with insulin. So the effects, insulin versus dulaglutide, hemoglobin A1C about the same. But this trial look on kidneys. And here you have a change of glomerular filtration rate with insulin. Insulin has no protected effects on the kidney. At long term, by improving glucose control, it may do, but in the short term, it does not. In contrast, the use of dulaglutide at the low dose, higher dose, did slow down the progression of decreased glomerular filtration rate. And here you have the effects on macroalbuminuria. Again, insulin bring the blood glucose down, but have no protected effects with respect to macroalbuminuria. Dulaglutide, in contrast, was associated with significant improvement in albuminuria. And this is just the semaglutide, although it was a 3,000 patient study, the SUSTAIN-6, that shows the 25% reduction in cardiovascular mortality. Also have new or worsened nephropathy, means albuminuria, and doubling of serum creatinine decreased by 30–40%. So this is why the 2021 ADA guidelines, the key message is that among patients with type 2 diabetes who have established atherosclerotic cardiovascular disease or established kidney disease, you should consider an SGLT2 that was presented in all these trials by Dr. Cosiboro, or the GLP1 that we're showing today, because they have been shown to improve beyond the use of the traditional medicines. And these were the guidelines for the American College of Endocrinology. It says we start on metformin, and we go to GLP1 and SGLT2 are the second agents. However, if you have a patient with atherosclerotic cardiovascular disease or chronic kidney disease with a GFR less than 60, or proteinuria, or reduced ejection fraction, you should consider GLP1 or SGLT2 with independent of hemoglobin A1C. And the new guidelines for AIDS is going to put in doubt, so you really have to start somebody with metformin before you use GLP1 or SGLT2. And I bring up to you, think about it, you see your patient is obese, have increased blood pressure, not very well controlled. Should you start on metformin, or maybe you should start on SGLT2s or GLP1? In 2020, the guidelines for the American Diabetes Association again says you start either way, GLP1 and SGLT2. And if you have heart failure, the data is very clear. If you want to reduce readmission to the hospital for heart failure, you should always use an SGLT2s before GLP1. GLP1 has very little effect on readmission for heart failure. So in the year 2021, this year, the American Diabetes Association said if you have a patient who has CKD, so a GFR less than 60, you should consider using GLP1 or SGLT2 because, as I show you, it decreased the slow down the progression of diabetic kidney disease. But if you have a patient with proteinuria, albuminuria, you should start, in addition to ACE, you should consider the use of SGLT2s. As a renal protected effects, the SGLT2 is better than GLP1. So I'm just going to put this together, this table, just to give you an idea where we are with the medication for diabetes, or the most common medicine. When you look at efficacy, they're about the same. One more than the others, like the weak points are DPP-4 and acarbose. Somewhere in the middle at metformin, sulfonylureas. SGLT2 only decreased hemoglobin A1c by 0.5, 0.6 to 1.9%. But the GLP1 and sulfonylureas are the same, and of course insulin at higher doses is good. There are different adverse events, that's right, safety. The GI side effects of GLP1 and metformin. Sulfonylureas. The Carolina trial showed 4-time increase in the risk of hypoglycemia. The only reason to use sulfonylurea is because they're cheap. Otherwise, I don't see why we should keep using it. The good thing is that utilization of sulfonylureas has come down significantly. Safety, DPP-4 is good, and insulin, of course, has hypoglycemia. But I hope that these 2 lectures today has convinced you on the need for cardiovascular and renal protection. We have no data on renal protection with metformin, no data on this neutral cardiovascular for DPP-4 and sulfonylureas, but there is no data on kidneys. So it was not until the last 5 years that we have learned and we have shifted our armamentarium to consider if you have patients at high cardiovascular risk or already with reduction of GFR, that you should consider using an SGLT2 or a GLP1 receptor agonist. So how can I summarize what I tried to mention today? So for many, many years, we have learned that if you bring the blood glucose down, you prevent the appearance of microvascular complications. No question. But that takes long periods of time. But if you have already a patient with established cardiovascular disease or renal disease, you have to go beyond glucose control. The other thing is that some of these agents, there are 2 agents that produce hypoglycemia, sulfonylureas and insulin. And we have learned if somebody develops hypoglycemia, there is an increased risk of cardiovascular events. So if you have metformin, if you go into sulfonylureas or insulin, you increase the risk of cardiovascular events. You should look for alternative. And the alternative right now that I believe you hope that we convince you today are to use early on the use of GLP1 or SGLT2s in the way that they have shown to have decreased major cardiovascular events and a renal protection effect. So I thank you very much, and I hope to answer any question that you may have.